The content of this podcast is for informational purposes only and should not be considered medical advice. Always consult with a qualified healthcare professional for any health concerns. Take care of yourself out there. Welcome to Unravelling, a podcast that sees the world through the lens of mental health. I'm Kurt White, a social worker and psychotherapist.
And I'm Mary Wilson, a journalist.
Now, Mary, last episode we talked to Professor Namdi Pol from Smith College about his course, The Psychology of the Black Experience, and we got into a lot of complexity about that, didn't we?
Oh, definitely. And we're continuing that discussion today, but taking a little bit of a narrower focus, and we're really turning that focus to Black women and the systemic barriers that they face, the resilience and the cultural expectations, all of these intersecting to really shape their lives.
Yes, I think that's a really interesting. And I was left in our last episode with that feeling that to understand something like the psychology of an experience of a group, like in that case, the Black experience or the experience of Black women or Black men, that there are obvious differences here, but to get at sort of what kind of thread and commonality there are, you have to look inside the mental health field, but also I think outside of it. He ended up sort of studying sociology and history and other disciplines, linguistics even sometimes he talks about, in trying to understand all of these things. And I think our guest today is similarly interested in this, right? She's a clinician, but also a researcher and someone who's looking at the effects of the larger society and world at large on this experience of Black women and how it affects their mental health and also how they might show up and present asking for help.
Yeah, she really has that wide overview and perspective that we're looking for. And it's Dr. Zoeann Finzi-Adams. She's a licensed psychologist and assistant professor at Howard University. She has a private practice as well, focused on women of color. And her current research agenda includes Black maternal health and high-functioning anxiety and depression among Black women. She's based in Washington, D.C.
I can't wait to learn from her and hear what she has to say.
Yes, let's get right into it. Dr. Finzi-Adams, welcome to Unravelling. Thanks so much for joining me.
Oh, thanks so much for having me.
I know you're very busy with teaching, research, but I understand you also have a private practice that focuses on women of color. What was your inspiration in establishing that?
Sure. So for a long time, I worked in university counseling center spaces. And then I found myself having these unique positions where I had a lot of experience with working with or unique opportunities to work with, let's say, minorities or underserved populations, and then particularly students and people of color. So as I think with every career, as you kind of advance, you have a little bit more agency in terms of the populations that you work with. And I think particularly, obviously, being a Black woman, those areas of concern were directly kind of relevant to my experiences and a lot of the experiences of the people in my community. So it kind of evolved over time where both my research and clinical interests around the experiences of women of color and the multifaceted kind of unique lived experiences that results in a litany of mental health experiences kind of evolved, and it kind of narrowed as well as expanded. I would say, I think narrowed in terms of the groups, but I think it's expanded in terms of understanding the nuances that are experienced by those populations. And so both my research and my kind of clinical practice really does serve primarily on women of color with a subspecialty around Black women, but I would say underserved minorities populations as well.
I know accessibility is a big issue here. Can you explain just a few of the top barriers you've seen in your practice that hinder the accessibility of mental health care for Black women?
There's a number of barriers. I think first we have cultural stigma, right? So that is the initial personal barrier of do I need it? Are things bad enough? Will this person understand me? Those kind of initial personal hurdles. Then it becomes, okay, I think I should probably talk to someone. Mm-hmm. Who do I think would be able to understand me? And I mean, this is not unique to Black women or women of color. I think most clients, when they're entering a clinical space where they're thinking about seeing a therapist, they're trying to think about understandability. And as humans, we do these quick, what do I think would make this person understand me? And it's often similarities, right? And we make a lot of snap judgments around, I think this person will understand who I am in the world because we have shared identities, or we move in the world, or we have certain values that align, right? So without knowing anything more about the clinician, I think people go to that first. So a lot of times women of color and Black women will think, I would love to see a Black woman clinician, right? I would love to see a clinician of color, and kind of as close to those shared identities as possible, in hopes that it will erase some concerns about invalidation or being misunderstood. And then it becomes just the accessibility, right? Are there enough clinicians in my area that meet those identities? You know, I live in the DC, Maryland, Virginia area. So it's a unique opportunity. I think we have a number of clinicians that kind of meet those demographic preferences, but that's not always the case, right? So then we have other barriers in terms of financial accessibility, time accessibility, right? Can I afford the person? Does my insurance cover them? Are they private pay? Can I afford that? If it's in person, can I go in person? If it's virtual, do I have the time? Do I have the allocated 50 minutes, however frequently, to see that person? So all those kind of hurdles just to get, and then do I have to call a consult? Are they available? Will they see me? All to then see if I can see this person at all. And those are just some of them. I mean, there's a lot of systemic ones too, to just getting in to see a clinician.
Systemic barriers. Can you talk about some of those?
Sure. So there is like these larger systemic barriers of like racism and sexism, and the unique experience of what we describe with Black women of this like double burden, which is not just experiencing racism that looks similar to other Black individuals, or sexism similar to all women. It's this unique interplay of Blackness and womanhood that is a unique experience as well too. The systemic impact of those three things have so many different implications, right? So it's how media, family, society communicates around how you show up in the world, how you present, what you should be worried about, what you shouldn't be worried about. So those kind of happen in all these like overarching ways, and all these like very intimate ways, in terms of also how women internalize that, right? So if you have your whole life thinking or being told in some covert and overt ways that the things that you are upset about are not that big of a deal, like you're just blowing things out, this is really not an issue, then you sometimes internalize that and say like, oh, am I questioning, should I be upset about this thing? Should I be nervous about this thing? Is this thing really happening? Or some people like overcompensate for that, and they have like a heightened level of vigilance of like, I'm assuming no one will understand me, everyone would invalidate me. So these like large macro things that have these unique every day, every moment implications to Black women. But then also there's like the other systemic things that are innately built in, right? We know about medical mistrust, right? And always trusting medical fields, or a lot of ways in which racism and sexism are really threaded through so much of our day-to-day kind of sectors, education, work, seeing providers in medical fields. So it really just happens all the time in this like wave experience. And then depending on a woman's awareness of those things, vigilance, ability to communicate and get those things validated, they may or may not always be cued in to what's happening, and thereby able to engage them in some ways that would be protective for them.
I know you're interested in studying group-based stressors and how they uniquely impact the mental health of Black women. So first of all, what are group-based stressors?
Sure. So for example, people with uteruses might be particularly concerned about access to menstruation products, right? So if they find that certain stores are not giving access to the certain kind of tampons or pads or things that they might want, like that would impact them and cause a unique stressor. So group-based stressors are stressors that impact groups differently because of their group affiliation. And that could be gender, race, sexual orientation, class, a unique group I'm a part of that has unique stressors that are related to that group.
Mm. And what are those mental health implications that you see specifically for Black women?
So as group-based stressors that would impact Black women, and just, again, looking at those two group-based membership, so being Black and being a woman, we have, again, the racism, sexism, and the interplay of that. So we see like higher rates of anxiety and depression among Black women as part of what's often called like this weathering experience, which is like this chronic exposure to discrimination and stereotype and distress as a result of being part of these two groups. We see a lot of sense of low self-esteem. And again, that's kind of aligned with this like constantly questioning yourself or being invalidated or kind of constantly vigilant. We see a lot of like internalization of some of these beliefs, right? This must mean something about me because I'm being treated this way. It must be something wrong with me because of these things happening to me. So, and it happens in so many different ways. I mean, I think when we think of racism and sexism, we think of like really aggressive, kind of pronounced presentations of it, versus there are these like small, like microaggressions, right? These little slights that really do impact us differently, right? So microaggression would be I'm at work and I am saying what a response to an idea. Let's say, like I say, I work in marketing. Oh, here's this marketing plan I have. And I'm dismissed. Like, I don't think that's a great idea. And then I have a male colleague repeat the same thing and then be like, oh, that's a great idea. And you're like, what? Did I just say that? I'm confused. Or I later talk to a supervisor about my reaction. And they're like, I felt like I was not heard. They're like, I think you're making something out of nothing. That colleague just seems to be a little bit, and maybe it's the way they communicated it, right? So it's these like really subtle slights that are really harmful. And again, not just Black women are not the only ones who experience microaggressions or kind of these things, but I'm just kind of describing how they manifest in Black women. So again, these like big, heavy hitter, when we think of stereotypes and discrimination, as well as these like smaller slights that we internalize or we're constantly in vigilance, cause a heightened sense of, oh my gosh, I need to be aware what's happening around me, or like this really defeating experience of like things are never going to change, which obviously could lead to anxiety or depression or a litany of other mental health experiences.
These microaggressions, it sounds like the intention behind it doesn't really matter. It's how it comes off and it's how it's interpreted, right?
Exactly. And I think that's why microaggressions could be really complicated, because they're confusing at times. And I would acknowledge even to the people who are doing it, because I think we all have our implicit and kind of beliefs that we are not always cued into, that we might be speaking from, right? So again, the implicits are like these unconscious, really ingrained beliefs that I maybe don't believe is a value I have, that shows up in the way that I maneuver the world, right? So in this hypothetical situation, one can argue if that supervisor is well-intended, and sometimes that supervisor doesn't have to be from an outside group. It could be another Black woman. They might be suggesting their strategies that they use to manage these things. Like, let's not cause any problems. It's not a big deal. But again, it's like these really slights that both maybe sometimes the person who said them is not always cued into, which then could be really complicated for the person experiencing them.
So what coping strategies do you see Black women sometimes rely on to navigate these systemic stressors?
Sure. So there are like passive as well as active processes that Black women would often use. So passive includes like avoidance and like internalizing, right? So avoidance, I don't want to address it. It's too much of an uphill battle. It's commonplace. There's nothing I can change about this. So I'm just going to avoid it altogether. I'm going to avoid people, situations, experiences, conversations. Then there's internalizing, which I mentioned is like this taking it in, making sense of it. It must be me. I'm always too sensitive, or I'm making something out of nothing, or there's something about me that is deserving of this. Then we have like these active processes that could both be productive and unproductive, right? So there's resistance, um, which can be good and bad. I mean, resistance can take a lot of different forms. It could be resistance in terms of like the social advocacy component of things. It could be resistance in terms of not allowing oneself to fully validate and experience that. Seeking support is a really productive and pro strategy, right? And that could be seeking support, not just from a mental health provider, from family, from friends, from community. And then there's always, again, like the combination, like avoiding triggers, right? I know this person is consistently problematic. I'm going to try to engage with them as little as possible, or not being in the wrong place or say the wrong things.
Mm. We often hear about the strong Black woman, an archetype of how maybe the ideal Black woman should act or behave. What does this mean, and what is the harm of this unrealistic stereotype?
So yeah, the strong Black woman is such, like you said, a really complex archetype, right? So at its face value, and in a lot of ways, it could be used as a mode of strength and resilience, right? Like I can conquer, I can overcome, I can persist in the face of life's complexities, the difficult things we kind of just went in depth about. The disadvantage of it is the knowing when help is needed. It can kind of create this opposite and negative interpretation if I need help, right? Strength is the goal. To be strong, to not show impact, to be able to persist. Like that is the ideal goal in this strong Black woman narrative. And the difficulty is that when we feel like we're not able to be strong, when we even feel weak or we need help, it is a failure, or it speaks negatively about our ability, which then why would I seek help for something that I think is something that I shouldn't be experiencing? I shouldn't be weak. I should be strong. So then that is obviously not going to create in one's mind the idea that I should have help, because why should I seek help for something that's wrong about me or speaks to a deficiency in my ability to handle?
Mm. Does this play out differently in the home versus maybe in the workplace?
That's a great question. I don't know if it's always setting specific. I mean, I imagine professional and home does require different versions of that. But I also think there's a lot of case by case basis depending on professional setting, home environments. So work strength looks like hitting deadlines, always being available, being responsive, not complaining. Home strength may looks like being everyone's caretaker, being really empathic, being warm, being available for everyone. So I think there is some kind of cueing in of like what it means to have it together and to be strong. But it both settings and across settings, I would say there is a common thread in the deprioritizing one's needs and just kind of rising to the occasion. But I think there's a number of variabilities that's really personal in terms of how a person comes to understand what their skills and strengths are in navigating environments. Like some people find that strength looks like for them being assertive and correct and being powerful. Some people identify strength as being passive and kind of getting out of the way, right? There's a lot of different presentations. And I think people's different home and work environments would obviously create some expectations around what that might be. But I don't know if I could say generally this is professional versus home. I think there's a lot of variability there.
Yeah, that makes sense. How can therapists and mental health practitioners incorporate these strengths into their approaches with treatment?
I think the best thing mental health professionals can do is be curious, right? I think even as myself, as I mentioned, a lot of Black women will come seek me because I'm a Black woman therapist who also specializes in Black womanhood. But I find it really important to never assume that their experience is going to be my experience. And it's difficult, right? Because sometimes we want these quick, I get what you mean, you can, without even saying. But I think being curious is really important, and not assuming we know whether something is positive or negative for a client. So, for example, if a Black woman comes in and says, I'm really just coming for work stressors, and then we hear this behavior of having it all together, and that's really important to me. Right. I don't think we should assume that's positive, nor should we assume that's a hindrance in terms of this strong Black woman. I think we can just be curious. You've mentioned a lot of times that for you, keeping it together is really important. Could you tell me a little bit more about how you came to understanding that's important to you? What are the advantages and disadvantages of having it all together? Right. So maintaining a curious but neutral kind of stance, because I don't think we want to go too quick to, oh, that must be the strong Black woman, we need to dismantle that, or, oh, this person seems like they're stuck and they're frozen in terms of inaction, and I want to dismantle that. Being curious around the function of a behavior, and if it aligns or disaligns with the client, I think is really important.
Curiosity. That's great advice there. Can you share some findings on your research on motherhood and Black maternal health and the implications there for mental health?
Sure. Right now, we are looking at some specific therapeutic approaches. Like, I'm really interested in an approach, theoretical orientation, relational cultural theory or relational cultural therapy, which really was birthed out of this reaction to the field of psychology that did a lot of pathologizing around how big of a priority relationships were for certain groups. And certain groups are usually women and communities of color. So they found that a lot of our diagnoses are related to how individual a person is, right? So, for example, codependence or borderline personality disorder are related to you. These relationships are too central for you. So then something must be wrong. And our goal is to individuate you, or I'm trying to think of another word than differentiated, but like your sense of yourself is separate than your relationships. This theory came to be because it was really challenging all of that, really. Like, why do we think this is wrong? And their belief is that connection is a fundamental goal and this thing that everyone wants. The way we get in our way is when the strategies that we use to connect are ineffective or problematic, right? So currently I've been looking at how that approach to relational cultural therapy works particularly well with Black mothers, particularly as it relates to, we can go a days about the stressors that a Black mothers experience in terms of maternal health crisis and Black motherhood and all those things. But the isolation is often a big part of what most mothers experience, but particularly Black mothers. And one of the biggest things that are helpful out of that is support. But if I feel like I shouldn't need support, like I know people won't understand, everyone else has it together, but I don't, then I'm not going to seek one of the things that could be most beneficial to me and my mental health. So I'm looking at this approach in particular and how it might be a good fit as it relates to challenging all those kind of paradigms. Like, why do you think you shouldn't need relationships? Why do you think it's bad that social support is so important to you? Like, completely dismantling this idea that it's a weakness or an inferiority that you need this much support or that you want this much support, right? So that's kind of where I'm looking at now, is how that approach and other approaches that challenge what we know to be helpful coping strategies for Black women and Black mothers, and how these components of support are so integral, and how different theoretical approaches might be better fit at encouraging those.
It sounds like the strengths and resilience here, it's such a double-edged sword where it gives you the resilience, but then also prevents people from seeking help or feeling like they deserve that help.
Absolutely. I mean, I think of so many clients where just realizing that they're allowed to ask for help is like the change. And you could tell someone for days that, but once they experience that, you're like, because it's bidirectional. It's not just you are helping me, so I am inferior, people feel good about helping. So you're also helping someone feel good to helping you, which then in turns allow for you to be a help to them. So this like very bi-directional, two-way benefit that relationships have that is really so instrumental for kind of challenging this isolation and silencing that a lot of Black women and Black mothers experience.
Mm. So what areas of research or practice do you feel are really most urgently needed to improve the mental health outcomes for Black women?
I would say, not in a hierarchical way, but I think right now there's a lot of attention and a lot of significance being put towards the Black maternal health crisis, right? So Black women, regardless of class, access to prenatal care, are uniquely susceptible to a lot of negative health outcomes through the birthing and postpartum experience. There's actually been an organization called Birth Fund that was developed by a number of celebrities, Serena Williams being one of them, Elaine Welteroth. A number of them came together, just really committed to addressing what they understand to be, again, a very complex process, but at least taking one leg of it. And that includes access to doulas, midwifery, access to other kind of postpartum and peripartum care. The attention being put on that right now and what we see like really devastating statistics regarding how this population is impacted. I think that's a really good opportunity for a lot of research, not just as it relates to when a woman is pregnant, not just like the year postpartum, but the impact it has long term in terms of depending a number of consequences or traumatic events that may have occurred throughout that process.
Mm. Increased access, increased research. How else do you envision the field of mental health sort of evolving to better serve Black women?
Yeah, I think much like kind of what the intention of this podcast is, right? I think being thoughtful and being curious, showing intentionality, right? I think one of the most significant questions you can ask a client is, what identities do you have that are significantly salient to you in the world, significantly salient to what brings you to therapy? How do you think being a Black woman impacts how you see the world? How do you think working with me as a Black woman might support or impact your ability to communicate or talk about some of those things, right? So I think if nothing else, showing this is important, showing that I know this is something important, and I don't have to know it's important by knowing the things that are important to you, right? Because I think that loses an individual aspects of things, but I can know enough, right? I know that Black women experience racism, sexism, kind of this double burden, kind of shared gendered racism. I'm curious of what that looks like for you. And if you're saying, oh, it doesn't, okay, I'm not here to tell you things that don't exist for you, but I'm letting you know that these are things that we can talk about. And I think asking those questions that could be uncomfortable are really important, and learn more. I mean, there's so many great conferences that happen. Continue to be curious, continue to stretch yourself regardless of your position to Black womanhood. Be curious of like, how can I learn more? How can I provide best services? Particularly for clinicians, again, researchers and stuff like that have different call to action. But I think clinicians can really be thoughtful, ask the hard questions, bring the things into the room, and allow your clients to know this is something I'm open to talking about.
Keep learning and stay curious.
Absolutely.
Well, thank you so much, Dr. Finzi-Adams, for being on the podcast. This was such an insightful conversation. Really, thank you for joining me.
Great. Thank you so much for having me. It's such an important conversation. Thank you for facilitating it.
Joining me again now is Kurt. Kurt, she talked a lot about creating a mental health space that would sort of be empowering and validating to Black women. I wonder what landed for you as someone in that field.
Oh, it was just a pleasure to listen to her. I definitely felt her as a psychotherapy colleague in that way, as well as a researcher and someone with a deep knowledge and personal experience of lots of different fields. It just gave me so much to think about, like, for example, the sort of archetype or narrative of the strong black woman, and how that, can cut in multiple ways and prevent people from asking for help or admitting their vulnerability or even sort of feeling like they have to live up to a standard of strength that is really not sort of realistic in the world for any human being.
Yeah, the invisibility of that struggle, too, and having someone feel like they have to hold it all together, that's such a weight to bear.
That's right. And again, of course, the deep effect of racism as well as gender in this intersectional way on the individual lived experience of folks that she's working with and folks that she's looking to understand more about in research, and the way that this shows up in physical health, mental health, and all sorts of different ways, and what we can do about it.
Yeah. And if you'd like to learn more, Dr. Finzi-Adams provided us with a bunch of great resources, including thebirthfund.com, which is an organization all about Black maternal health and improving the outcomes there for Black women. We'll list that and a few other resources in our show notes.
I hope people get a chance to look at those. And thank you again, Mary.
Thank you.
Unravelling is brought to you by Brattleboro Retreat. Our producers at Charts and Leisure are Andrew Atkin, Hans Buetow, and Jason Oberholzer.
And you can find us on social media by searching Brattleboro Retreat. Brattleboro Retreat is committed to exploring diverse perspectives on mental health. While we invite hosts and guests to share their insights, the views expressed are their own and do not necessarily reflect the policies or positions of the hospital or its staff.